So take 5 seconds to pause the video, read the question, and then we'll go through the answer. Okay, so we have a 67-year-old left-handed male. He's coming to the emergency room for 9 out of 10 chest pain that began after a game of ping pong at his senior living facility. The patient states that he has been non-compliant with his statin medication, non-compliant, and has not been consistent in checking his blood pressure at home. He reports having chest pain over the past week. Key part right here, worsened with rapid left arm movements, That's important. His medical history is significant for, again, also important, myocardial infarction secondary to significant stenosis of the left anterior descending and circumflex arteries. He has previously undergone a coronary bypass grafting procedure. Physical exam reveals a cool left extremity, with a 1+ left radial pulse. The right upper extremity is normal in color. Systolic blood pressure is 30 greater than the left. Cardiovascular surgery is emergently consulted, and a percutaneous revascularization is performed. So the question is, retrograde transport of blood through which of the following arteries most likely contributed to the patient's presentation? And I'm leaving you in suspense again, not on purpose, I promise. But the answer here is the patient is getting retrograde transport through the grafted internal thoracic artery. So let's just take a look at this. So, just to kind of elaborate, this is the diagram I showed you earlier when we talked about subclavian stenosis. The patient previously had a grafting procedure. So they grafted structure here. Most likely, we said one of the structures is the internal thoracic or internal mammary artery. Now, when they perform these grafts, they usually are going to put that structure, kind of in this region. So they have a grafted artery, and that grafted artery is going to go, to the subclavian vessel. I'm going to say this is the patient's heart. And so this grafted artery is coming down here to supply these vessels. So under normal conditions, my aorta is going to eject blood, and then I'm going to get additional blood through the graft. That's the concept. But the problem here is I have an area, this patient who's poorly compliant with his statin medication, probably has some atherosclerosis, especially in the setting of this history of previous myocardial infarction. So this patient who has activity that's worsened with a rapid left arm movement, very classic for subclavian stenosis. The patient tends to have the chest pain come on when he's moving his left arm. So because the concept is, because this patient has this area of stenosis here, there's actually a steal phenomenon going on here where we're stealing some of this blood and it's going retrograde distal to the obstruction, because if the narrowing is significant enough, remember we talked about, if the narrowing is significant enough distal to the subclavian artery, the vertebral blood flow will start to kind of flow retrograde. And the same concept is true for all of these distal arteries, just like the grafted internal thoracic artery. You're going to get retrograde blood flow here as well to supply this region that has a decreased pressure, It's just hemodynamics, I'm decreasing the pressure distally, so these areas are compensating through retrograde flow. Because I'm stealing blood flow from my heart now, though, these coronary vessels that are probably already dilated significantly, this patient has a significant myocardial history, this area is now being compromised of blood flow. So by moving the left arm, I'm stealing more blood flow from the graft as well as this left vertebral artery, and I'm going to induce angina in this patient and potentially vertebrobasilar symptoms as well. And so this actually is a specific type of subclavian steal. It's known as coronary subclavian steal. You can call it coronary graft subclavian steal. And so that's the concept. Let's just go through the other options here really quickly. So right vertebral artery. So I have no problems with ejection of blood going this way. It's really the retrograde transport down the left side that's happening because of this decreased pressure. So we wouldn't expect any retrograde flow through the right vertebral artery. If anything, we have more flow going in the correct direction in the right vertebral artery. The left subclavian artery shouldn't have retrograde flow, We actually have, overall, we have decreased flow through the left subclavian artery because of this area of stenosis. So that would not be correct. Retrograde flow through the left internal carotid artery. So the common carotid artery comes off proximal to this narrowing in the subclavian vessel. And so we actually would get some of that flow from the internal carotid artery to come back down the left vertebral. So there should be no retrograde flow through the internal carotid artery either. for that reason. Again, that's because the common carotid comes off proximal. The pressure drop is going to be distal to the subclavian artery. So all distal structures will tend to be affected more so for retrograde transport. Left axillary artery, same concept. We're going to have an overall decrease in pressure going through this region. That's evidenced by the fact that there's a 1+ radial pulse. The extremities are cool. There's a decreased pressure on the left side. We wouldn't expect retrograde flow through the left axillary artery. We just have decreased flow. And so the correct answer here would be the grafted internal thoracic artery having retrograde flow to compensate for the decreased pressure distal to the stenosis in the subclavian vessel. Another right answer here, it would be if one option was the left vertebral artery. Okay, that would also be a correct answer. Okay, and I know this question was a little bit harder. I kind of forced you to think a little bit. It's a good exercise to kind of think through these problems because it helps you understand the anatomical considerations you need to answer some of these.